Today we are going to discuss pleural effusion. Pleural effusion means accumulation of fluid between parietal pleura and visceral pleura. If the accumulation is of a purulent fluid, a pus is accumulated, gross pus is accumulated between the parietal and the visceral pleura, then it is known as empyema. A minimum of 500 ml is required to be detected clinically. Now, what are the mechanisms by which fluid is accumulated between the two layers of the pleura? One could be increased hydrostatic pressure. Increased hydrostatic pressure example could be right heart failure when there is increased venous pressure. Or there could be decreased plasma oncotic pressure or increased pleural oncotic pressure. Okay. And there could be increased capillary permeability, maybe because of local inflammation or toxin or some vasoactive substances. Example is pancreatitis or pneumonia. Then there could be transfer of ascitic fluid across the diaphragmatic defects. Then there could be increased negative pressure in the pleural space, or could be because of obstruction of lymphatics. Okay, so these are the mechanisms of accumulation of fluid between the pleural space. Now coming to the causes of pleural effusion. Now the causes could be either transudative or could be exudative pleural effusion. Now what are the causes of transudative, which is usually bilateral? It could be CHF, it could be cirrhosis of liver, it could be nephrotic syndrome, severe malnutrition or hypoalbuminemia, myxedema, constrictive pericarditis, superior vena cava obstruction, or Budd-Chiari syndrome, or peritoneal dialysis. In exudative pleural effusion, causes could be infections like pneumonia and TB, could be neoplasm, metastatic, example bronchogenic carcinoma or mesothelioma, pulmonary embolism, collagen vascular disease like rheumatoid arthritis, SLE, sarcoidosis, Sjogren, vaginal granulomatosis, Churg-Strauss, then gastrointestinal causes like esophageal perforation or pancreatitis, uremia, renal failure, post-CABG, then asbestosis, then some drug-induced could also be there, bromocriptine, amiodarone, nitrofurantoin, and dantrolene. Then exudative के example continuing the continuation में Meek syndrome could also be one. Meek syndrome means ovarian fibroma plus ascites plus right-sided pleural effusion, chylothorax, hemothorax, then radiation therapy. If they ask what are the predominant causes of left-sided pleural effusion, then there is a mnemonic POD, pancreatitis, esophageal rupture, and Dressler syndrome, which is seen in post-myocardial infarction. Right-sided effusions predominant. The causes are amoebic liver abscess, cirrhosis of liver, CHF, and Meek syndrome. Now, what are the differences between exudative and transudative pleural effusion? On physical appearance, the color. Color could be amber colored or could be colorless in transudative. Consistency, they are sticky, it is non-sticky. On shaking, froth formation occur, doesn't occur. On standing, clot formation occur, doesn't occur. Aspiration में slowly flow करेगा, viscous है, fast flow करेगा. Specific gravity will be more than 1018, less होगा यहाँ पर because cells are present more. They have only few cells over here. And there is a Light's criteria which says pleural fluid protein upon serum protein more than 0.5, less than 0.5. Pleural fluid LDH upon serum LDH more than 0.6, less than 0.6. Then pleural fluid LDH more than 2/3 of the upper limit of the normal value of serum LDH, and here it is less than the 2/3 of the upper limit of the normal value of serum LDH. So any one is present, then it is exudative pleural effusion. Okay, glucose less than 60 and glucose more than 60, LDH less than 200, LDH more than 200. So these are the difference between pleural exudative or transudative pleural effusions. Okay, and now we'll go to clinical features.